Good morning, students. I am here to present you the third part of my discussion, that is the arterial supply of the stomach. So you can see the diagram of the stomach and its arterial supply. For the sake of discussion, now the major arterial supply of the stomach comes from this artery, which is called the left gastric artery. And this left gastric artery is a branch of celiac trunk. Now, this celiac trunk is a branch of abdominal aorta. This left gastric artery reaches the lesser curvature of the stomach through the lesser omentum and run along the lesser curvature of the stomach to anastomose with another artery, which is called the right gastric artery, along the lesser curvature. Now, this left gastric artery will supply the two-thirds of the organ. The right gastric artery, which is the branch of common hepatic artery, will also run along the lesser curvature of the stomach and anastomose with the left gastric artery. Along the left border of the stomach, that is the greater curvature, the fundal part will be supplied by the short gastric artery. This one, the short gastric artery, which are the branches of the splenic artery. Now, this splenic artery is a tortuous artery which will pass on the posterior aspect of the stomach. Now, the branch of the splenic artery is the short gastric artery, which will supply the fundus of the stomach. Sometimes there are few branches which is called the posterior gastric artery, which arise from the splenic artery and supply the posterior aspect of the fundus of the stomach. Along the greater curvature of the stomach, another branch is the left gastroepiploic artery. Now, this left gastroepiploic artery pass along the gastrosplenic ligament and reach the greater curvature of the stomach and run along the greater curvature of the stomach to anastomose with another artery, which is called the right gastroepiploic artery. Now, this right gastroepiploic artery, which is the branch of superior pancreatic duodenal artery, will run along the greater curvature of the stomach to anastomose with the left gastroepiploic artery. Now, the branches from this arterial arcade along the lesser and greater curvature will supply the adjoining areas of both surfaces of the stomach and run almost at the right angle with the long axis of the organ. This is like that. So the branches from this arterial arcade will enter through the wall of the stomach, almost perpendicular with the long axis of it. Now, what happened with after entering the artery? Now, to show you what happened after entering through the wall of the stomach, we need to look into the histology of the wall. Now, by this time, you all know from inside outward, the wall of the stomach consists of 4 layers. Now, what are the 4 layers? The mucosa, the submucosa, the muscular layer, and the serous layer. Now, the arteries will pierce the serosal layer, then muscle layer, then reach the submucosa. Now, at the level of submucosa, there will be intense interarterial anastomotic network present within the wall of the stomach. And from this anastomotic network, the arteries will pierce this layer, that is the muscularis mucosae, and reach the lamina propria to reach the base of the epithelium. Now, here also there will be intense interarterial anastomotic network before it forms the capillaries. There are some conditions like in uh, in lesser curvature of the stomach, this interarterial anastomotic network is absent at the level of submucosa. That is why the artery, মানে major artery that enters through the wall of the stomach will reach directly to the subepithelial layer. Now, as it reaches directly to the subepithelial layer, there is always chances of necrosis if there is any constriction during its course. That is why the lesser curvature of the stomach is more prone of having peptic ulcer disease. Also, at the submucosal layer, there is intense arterio-venous anastomotic network present. Now, these arterio-venous anastomotic network uh, having a dilated channels. Now, these dilated channels are become more dilated where there is persistent hyperchlorhydria. Means when there is persistent acidic environment, this arteriovenous network become more dilated. That is why there will be shunting of the blood through this layer, and there will be no blood at the subepithelial layer. That may produce ischemic necrosis at the epithelia, thus a, a seat for formation of peptic ulcer diseases. Now, these are the two conditions we commonly encounter in the stomach in day-to-day practices. Now, coming to the venous drainage of it, and the arterial network will follow the venous drainage. The venous drainage will follow the arterial network. Now, the major venous drainage is this vein that is called the portal vein. Now, this portal vein, the left gastric vein, this one, the left gastric vein and the right gastric vein, both drain directly within the portal vein. Now, this portal vein has been formed by these two veins, that is the superior mesenteric vein and the splenic vein. This splenic vein and the superior mesenteric vein will unite to form this portal vein. And within this splenic vein, the short gastric vein drains, also the left gastroepiploic vein drains, in the inferior mesenteric vein also drain. Now, the right gastroepiploic vein drain in the superior mesenteric vein. So, this is the venous drainage of the stomach. Now, one important thing you have to remember that there is a portocaval anastomosis present around the stomach near its cardiac end. Now, what happens? This is the esophageal branch of the left gastric vein, which drains in the portal vein, and this is the branch of the hemi-inferior division of the hemiazygos vein, and these two will unite. Now, this is the caval part, and this is the portal part, and that is why there is portocaval anastomosis present at the cardiac end of the stomach. Now, when there is a portal hypertension or portal obstruction, these veins will dilate and form this esophageal varices. Varices. Varices we commonly know as a hemorrhoid. We commonly know as a hemorrhoids, and these varices will often bleed in the portal obstruction. Now, this completes the venous drainage of the stomach. Now, come to the lymphatic drainage of the stomach, which begins from the subepithelial level. Now, I have shown you the histology of the stomach, and from the subepithelial level, the lymphatic channel begins, and subsequently it will form the submucosal plexus, and then sub, then intramuscular, then subserosal, then it will pierce the serosa and reach outside as a lymphatic channel. Now, for the sake of discussion, I need to divide the stomach into two parts by a vertical line. This vertical line, this vertical line I have drawn, and this vertical line divides the stomach into right and left part. Now, on the right side of the stomach, along the lesser curvature, the lymphatic drainage will be within this gas left gastric lymphatic lymph node. Now, on the right side of the vertical line, the lymphatic drainage will be towards the pancreaticosplenic node. Now, if I divide the right part into upper two-third and lower one-third, the lower one-third part will be will the lymphatic channels will pass through this right gastroepiploic node and pyloric nodes, and few lymphatic channels will reach the right gastric node, and this right gastric and left gastric ultimately terminate into the celiac nodes. Now, there are some peculiarities in lymphatic supply of the lymphatic drainage of the stomach. Now, uh, the the lymphatic drainage is continuous of the stomach is continuous above. The lymphatic drainage of the stomach is continuous above at, at the esophagus, but it is restricted. It is restricted below or distally at the duodenum. There are few factors which are responsible for this sort of lymphatic supply because of the muscle coat of the stomach. Now, the muscle coat of the stomach, the longitudinal muscle coat at the level of pyloric end will invaginate and continuous with the pyloric sphincter. Thus, the muscle coat of the stomach is not continuous with the muscle coat of the duodenum. Also, the at the cardiac end, what happens? The muscle coat of the stomach, that is the circular muscle coat, is continuous with the muscle coat of the esophagus. That is why the uh, submucosal or uh, sorry muscular lymphatic plexus is continuous with the esophageal lymphatic plexus. And that is why, if there is any carcinoma in the stomach, this will spread towards the esophagus, but it will not gonna spread at the duodenum. Also, so there is a watershed zone present in the lymphatic drainage of the stomach. Also, the lymphatic channels of the stomach presented with the valve. That is why the right side of the stomach along of the vertical line will the lymphatic drainage has to be continuous with the left gastric side, or towards the left right side, and of the left side of the vertical line, the lymphatic drainage is towards the left side, that is the pancreaticosplenic node, right? So it will not never be the opposite one. Means the greater curvature of the lymphatics from the greater curvature will not gonna pass to the left side or to the left gastric node. It has to be towards the pancreaticosplenic. So this concludes my discussion. Thank you very much. Thank you very much for